Is podcasting doable only in teenagers? No. The literature says that we can also do it in adults. So in this case, elective treatment, old amalgam restoration that starts losing the seal. I remove the decay, and when I'm finished removing the decay, there are two small communications between the pulp chamber and the cavity. And so what do? Direct pulp capping. I explain to the patient we are taking a risk. She might need an endodontic treatment sooner or later. Okay, I put the MTA with the MAP system, which is the most easy way to deliver MTA where you want to. And then I use a microbrush to gently adapt it to those two small cavities. I remove the excesses, and then I go grab a coffee, because MTA is going to start setting in 15 minutes. I check the hardening of the MTA, and then I can go on with my direct restoration. So I do the total latching procedure, enamel first for 15 seconds, then tint them for 15 seconds, and then I go on with the application of the primer and the bonding, and I do the direct restoration in composite. Simple. This is the result. 1 year later, the restoration is still there, and the tooth is like this. There was a pulp stone before, there is a pulp stone now. I have no periapical symptoms. The tooth is vital. So we bought time for our patient. We postpone any possible endodontic treatment because this is how it has to be done. So when do I do endodontic treatment? When I have irreversible pulp pathology, there is no other way to treat the tooth. Or when the pulp is necrotic, we have no option. Or, and this is an elective treatment, when we know that our procedure are going to compromise the vitality of the pulp. For example, I have to place a crown on a tooth, so I have to do my preparation, but I see from the x-ray that the pulp chamber is so close to the finishing of my preparation that, to be sure, I decided to do the endodontic treatment. Or when there are traumatized teeth that are avulsed or dislocated. Or again, with internal resorptions or external resorption who go interesting the pulp. Or when I have cracks or fractures that the pulp is involved. Or when the patient has a crazy hypersensitivity and we are not able to manage it any other way. We do the endodontic treatment. But all over the world, all of the scientific society agree that there is no successful endodontic treatment if we don't use the rubber dam, because isolation is mandatory in order to succeed. And what the vast majority of the dentists that don't use the rubber dam say is that it takes a lot of time to put the rubber dam on. Well, it takes from 20 to 60 seconds. So that's not the excuse. And one might complain about the fact that patients don't like the rubber dam. It's 1.5% the number of patients not accepting the rubber dam. All of the others, if informed correctly, accept the rubber dam. And most of them, at the end of the procedure, tell you, oh, doctor, this is so comfortable. So we only have benefits in using the rubber dam because we see better what we are doing. We have an improved access to the area because we remove all what can interfere with our concentration. We protect and retract the soft tissues. Did it ever happen to you to cut the cheek or the lips or the tongue of your patient with a burr or a disc. With rubber dam, this doesn't happen. And also, you protect the patient from ingesting what you are using. Burrs, pus, irrigants, blood, whatever. It stays outside of the mouth of the patient. And you have one hand free because you're not holding the cheek with your hand. And also, you have a better outcome. You reduce the time of the therapy and you have legal protection. And post-COVID, the only treatment that we were accepting to do were those in which we could use the rubber dam because it was protecting us. And this is what happens. That patient ingested a matrix, this patient ingested a file. This can be a huge problem for you if it happens in your practice. And if one has the excuse that I don't have the rubber dam because it's expensive, my question is, do you have gloves in your practice? Here is a homemade video with an extremely sophisticated tool, a pair of scissors, that show you how to make rubber dam out of a glove, one single glove. You can do it yourself, or if you have an assistant, you can do it with an assistant. The result is the same. You cut the thumb first, then you cut the other fingers. And then, if the assistants help you, you're even quicker. And then you open up the side of the glove. You open it up and you have a latex sheet. And I cut that part because it doesn't look nice. Then you take your punch and you do the holes inside of the latex. You place your clamp, you open it with a forceps, and you're ready to go. The cheapest rubber dam, so no excuse for not using it. What are the timings of endodontic treatment? We saw diagnosis, access cavity, mechanical shaping. That takes a short time. I take a lot of time to do my access, a short time for shaping. Then cleaning, long time. And then restoration. In this case, I saw this patient and she has pain on the upper right part of the face. You see she has a bridge and there is a large leakage over there. But the tooth responsible for her pain was the second premolar because she had irreversible pulpitis. That tooth was already half necrotic. So what do? I start from the chief complaint. I do the endodontic treatment on the premolar. So you see I have removed the bridge and I have placed the rubber dam with a clamp that you usually have to use in incisor, but the size of the premolar is small, so this is the best fitting clamp. I remove all the decay first, and then with ultrasonic tips, I go designing my access cavity. I want to remove completely the floor of the pulp chamber. I irrigate because I see nothing, and I cannot shape when there is an extensive bleeding. And then I do a completely mechanical preparation of the root canal. I use this file, which is called PX, and it is a file designed for making the glide path. I use it in the coronal 2/3 of the canal, then I switched to a 20.0.4 integer file. I use it only in the coronal and middle third. The same with a 25.06, only in the coronal and the middle third. What did I do? I did coronal pre-flaring. I removed all of the obstacles between me and the apex. And then I can take my manual, number 10, K5, and check the working length. And so I can bring to the working length the 3 files you have seen before. So I bring my glide path file, I bring the 20.04 file, and I bring the 25.06 file. What am I searching for? I'm searching for my visual gauging. That means that the tip of my file has to be covered in white dentine. This is the sign that I have shaped the apex. If I hadn't this kind of feeling, I would pick a larger diameter file and I would pass it. I am finished with my shaping in few minutes. Then I spend most of the time irrigating and activating the irrigant, because we have to remember that we shape to clean, to allow a larger volume of irrigant to flow towards the apical third of the tooth, which is the part of the tooth in which we have the highest concentration of anatomic variation of bacteria, so we need to clean over there. And then I check the fit of my gutta-percha point. I have to feel some resistance while I try to take it out of the root canal. This is called the tag back. And then again, I try the canal, I put my bioceramic sealer on the gutta-percha point, and I fit it into the tooth. At this point, I'm finished with my endodontic therapy. I only have to cut the part of the gutta-percha point that is coming out from the orifice. And I do it with a heat plugger. And then I plug the gutta-percha. And if I did the single cone technique, I will be done here. I want to do a warm vertical compaction technique. So what do? I set my plugger 4 millimeters short from the working length, and I go heating the gutta-percha down there, and I pack it. I heat and I pack. This allows me having a more dense obturation and increases the chance of filling lateral canals, for example. This is how clean your cavity has to be if you want to proceed with the therapy, and with bioceramics it's very easy to achieve this goal. And then what do? I restore the tooth and I take care of the other in a following appointment. And to put the rubber down there, I had to do a small preendo build-up. And this is the treatment of the second molar. This is a similar situation, but with a necrotic tooth. You see the lesion on the first premolar. I do the same. I remove the bridge, I do the endodontic treatment, and since the patient has no money and she wants me to save her existing bridge, I do it. I place a fiber post and I do a post-endodontic restoration and I use her bridge. And she, 8 years later, is still like this. So we can do also affordable endodontics. Sometimes it's not so easy to determine the chief complaint. It was a Saturday at midday, and this patient came as an emergency appointment in my practice. She lives in Verona, which is 2 hours away from where I work. And she arrived crying because she hasn't slept for 2 days, because she was in pain. And I asked her, what is the reason of your pain? What exacerbates your pain? And she was like, I'm in pain with cold, with hot, and when I bite. So the whole pool of symptoms And so, she tells me that she has received a pulpotomy on the second molar some days before, but she still has pain, maybe even more than before. So help me. What is the tooth responsible for her pain with cold? Raise your hands. Second molar, first molar, or second premolar? Who says that it's the second molar, the responsible for the pain with cold? Nobody. Who says it's the first molar? Nobody. So we all agree that is the second premolar, the responsible for her pain with cold. Yes, because it has an irreversible pulpitis, a large decay close to the pulp. And the responsible for the pain with pulp is obviously the second molar, in which they attempted to do a pulpotomy, but they left the pulp inside. And so the pulp pathology went on, and so now she feels pain with pulp, and she's relieved by the cold. And the precaution is obviously the medial root of the first molar, because there is an endodontic lesion with a poor endodontic treatment. And now that's the problem. 3 teeth with problems. What do I do first? I call my husband, I tell him, don't wait for me, and I do the endo on the second molar. I remove all of the existing filling from the first molar, and I do a pulpotomy on the second premolar. And if you watch carefully the x-ray, you know why I didn't try to do the endodontic treatment on the second premolar in the same visit. Because it has 3 separate roots with 3 root canals, so it's difficult. I want my mind to be fresh when I have to do such a case. And so, in the second appointment, I did finish the retreatment on the first molar, and I did the treatment on the second premolar. So I finished my endo. And I'm like, you can't have the restoration at your dentist in Verona, because I'm very far from you. I don't want you to drive for 2 hours. I have solved the endodontic problem. And this is where I did a mistake. Because look at this restoration. There is no seal here. And so there will be coronal leakage. Despite this, the endodontic succeeded because the lesion disappeared as she is symptom-free. But there's a restorative failure, so I don't know how my endo success will last. Because bacteria can come inside the root canal and reinfect everything again. And there's another problem. Big decay here, big decay here. So I tell her, get a restoration. Yeah. And so she comes up again. And she has had a pulpotomy in Verona. And they did it wrong because they didn't understand. And also these two have 3 separate roots. And you can see it clearly from the preoperative x-ray. So the shape of their axis was that one. The shape of the correct axis is this one, because we have 2 buccal roots. And so 3 root canals. The sequence, the same I explained you before. So I used a small 15 in tape, 3% in taper 5 for the glide path, 2004, 2506. I did the coronal preflaring, and then I took all the files to the working length. And this is the working length determination, and this is post-operative. And this time I also did the restoration, just to be sure. And the curiosity, the rarer the anatomic aberration, the more frequently the patient has it on both sides. You see, 3 roots, 2 canals, 3 roots, 3 canals. So if you find a patient with a particular anatomy, think that probably the same tooth on the opposite arch will have the same anatomy. But I want to see what I do. It's the only way in which I can work correctly. So I have to do a correct access cavity. Because if I don't do a correct access cavity, I'm not finding the ambito canal in upper molars. I'm not finding the medial mesial canal in lower molars. So I have to do an access cavity that allows me doing a correct shaping, cleaning, filling. Because if the access cavity is wrong for position, depth, extension, the possibility that I have a success are low, extremely low. And so what are the access cavities that we can do? We can stick to the conventional access cavity. We can try a more conservative approach. We can do a truss access or a ninja access. What's the difference? With a conventional access cavity, I completely remove the pulp chamber and I can completely see the anatomy. The guidelines say that you have to see all the openings of the root canals without moving your mirror. So you see very well the anatomy. You need a basic education to do this kind of access. But you are removing a lot of dental tissue. And so you are decreasing the fracture strength of your tooth. That means that if you don't do the restoration in the first appointment, you might want to remove the tooth from occlusion. If you try to save more tooth structure, you can pick the conservative access. Because you still remove completely the pulp chamber, it requires higher skills. If you use magnifications, better. Because in this case, you still can see all the anatomy, but you have to move the mirror. And obviously, you save more structure, so you increase the fracture strength of the tooth. But we want to be extremely skilled, and we want to show the world that we are good at endo, so we can try to make a truss access and preserve the dentine bridge. So we are not going to do completely the pulp chamber. We need magnification, we need high skills, and of course we save tooth structure. But if you want to be extremely like a show-off, you can do this. You take a CBCT, because otherwise you don't know where to do this tiny hole, and then you try to find the root canal by passing through that tiny hole. The problem is that with this, you're not increasing the fracture strength of the tooth, and you're removing more dentine in the roots. So, if I have to give you an advice, don't take this kind of access. Do the conservative access, that is the right balance between seeing what you're doing and saving tooth structure. How do we do the access? We start with a small cavity done with a diamond-coated burr, and then we take the ultrasonics and we design the limits of the cavity. And since we have to make the cavity serve us, if the anatomy requires us to extend the cavity, we extend the cavity. This is what I advise you to do before doing an access cavity. Take your probe, take your x-ray and measure and see how deep is my cavity. Where is the pulp? 6 millimeters, okay. How long is my burr? 10. I will need 4 millimeters of my burr to stay outside of the tooth, and I'm sure I'm not going to perforate, for example. This is particularly useful when the pulp chamber is contracted, or you have extensive restorations. Measure with a reference point in order for this to help you in finding the root canal openings without wandering around with the burr. And pay attention to the inclination of the tooth, because if your tooth has crown, maybe the crown has not the same inclination as the root. And so, check your preoperative x-ray in order to be able to make a cavity with the correct inclination. So we have 3 steps to follow: preliminary endodontic access, enlargement, refinement. You've seen diamond-coated burrs for the preliminary access, enlargement with a multiple blade burr with a non-working tip. You put the tip of the burr on the floor of the pulp chamber, and then you go around enlarging. Then ultrasonic tips to refine the cavity, and then you find the orifices. To pass from that to this is 5 minutes, even less. So don't settle for this kind of access, because with this kind of access, if you don't remove these, you're letting inside of the tooth a lot of bacteria. You will not be able to clean correctly. So remove the pulp calculus, the whatever. You have to get this. So, what do? I do my radiographic evaluation. In the crown, what do I see? A decay. In the middle third, do I see something strange? No. In the apical third, big lesion. First thing, I do a clinical evaluation. There is a sinus trap. So I can feel immediately the root canals and I will have no problems, even if there is a huge infection. And then I isolate. I remove all the decay, all the restoration, all the unreliable dental tissue, because now I'm already starting to think about what restoration is best for this tooth. And then the map of darker colors on the pulp chamber guides you to find the root canals. You take your working length. This tooth had a large size. I can use the TDG6 because they're like pro-taper gold, so why not? I use them. And this is it. Immediately, I restore. 1 week later, the sinus tract is gone. 2 months later, the patient is like this. Do I always have to make a build-up before doing an endodontic treatment? As long as I can put my clamp, no, there is no need. These are the situations in which I do a pre-endodontic build-up, when there is no tooth left, because I also evaluate if the tooth is restorable or not. If the tooth is not restorable, I extract it. If the tooth is restorable, as in this case, I open a flap, I put my matrix, rubber dam, pre-endo build-up. And then in a second appointment, I do the endodontic treatment. This is no easy tooth. I need small tapered files because it's long and it's thin. So I choose the file according to the clinical situation. And then I fill single cone gutta percha, the easiest filling technique in the world. Treatment planning. What am I doing? 16 years old patient with a large decay, a large periapical lesion. It's impossible to place the rubber dam. So, as we have just seen, crown lengthening, open flap, pre-endo build-up, root canal, and then restoration. Always with these very flexible, small tapered files that help in managing this kind of situation. So, to summarize, if I have an intact tooth, I do a conservative access cavity. But how many intact teeth are we treating endodontically in our practice? Few. Most of the time, we treat teeth with restoration, with decays, so we do a careless-driven access. We remove all the restoration, all the decay, and then we do the access. If we cannot isolate, we do endodontic build-up. And if I do a retreatment, I always modify the access cavity, because 90% of retreatments are linked to the existence of a wrong access cavity that made the treatment fail. This is an example. This is a patient who requires a huge rehabilitation because he has lost vertical dimension, he has lost the molars, he's a bruxist, he has clenching, so he needs a big rehabilitation, and a colleague of mine does the rehabilitation. And he decides that he wants to do the endodontic treatment on the two lateral incisors. But he is no endodontist. He takes a panoramic X-ray as a preoperative. And so he doesn't see the anatomy of these teeth. And he tries to find the root canal in one tooth, and he doesn't, so he stops. He tries to find the root canal in the other tooth, and at a certain point the assistant keeps kicking in and says, "Stop, doctor." He stops and sends the patient to me. This is the preoperative that I did. The inclination was completely wrong. I think he perforated there. So I do a CBCT because I don't know what the situation is. Wrong access, nothing, because the tooth is calcified, it's a bruxist. And then the root canal. So I can treat it. I can find the root canal.
em nghe đây.
You see here, this is the most common
đúng rồi.
mistake in doing an access cavity and
Mấy giờ
incisor.
vậy anh? Mấy giờ?
The orientation of the burr is to buccal, and most of the
5 giờ có
people
mặt
end up
mấy
perforating
giờ xe
here.
chạy?
So the advice in this case is to always remember which is the anatomy of the teeth, remember the inclination,
Dạ dạ.
and
Cho em hỏi
isolate multiple teeth in order to
dạ,
act
5
as
giờ
a
5 giờ
reference
15 là xe chạy
to
đúng không anh?
nearby teeth.
Dạ dạ anh cảm ơn. Dạ.
So I correct the access, find the root canal, I do all of my cleaning, shaping, filling, etc. And this is the post-op. And I send the patient back to him for the restoration and the crown. And he's still alive. The same on the other side. CBCT, his cavity, my cavity, intro-op and post-op, and the follow-up. This is another problem, perforations, often due to a wrong access cavity. So, a colleague tried to retrieve this tooth, and he didn't find the canals. At a certain point, he found something that was bleeding. So he tried to clean and fill it with a thermofill. The patient was crazy in pain. So my colleague said, "Okay, I'm extracting the tooth." And the patient said, "No, I'm 40. I want my tooth. I don't want an implant." And I agree with the patient. So he sends me, the patient, to try to recover this tooth. I asked him for his pre-operative X-ray. You see, there was no perforation. He did it. Why? Because the inclination of his access cavity was wrong. He wasn't able to do this in order to find the opening of the nasal canals, and so he would not treat them, and he perforated. So I had to remove the thermofill from the perforation, and you have this kind of situation, bleeding, because the periapical tissues are very inflamed. So the only thing I can do in this moment is to seal the perforation with MTA and wait. I wait for a week. And when I see the patient in the second appointment, I control if the MTA is set. If it's set, I do the retreatment and the build-up, and I put a composite overlay because I don't want the patient to spend much money on this tooth. I do the retreatment, 6 months, and 1 year follow-up. I didn't save this tooth for all the life of the patient. I don't know how long it will last. But implants are not forever. So if he gets an implant at 60 instead of at 40, we all are fine with it. Shaping. What are the rules and the objectives? I want something that completely incorporates the original anatomy of the root canal. That means that all the surfaces of the root canal are prepared. But we know that no existing endodontic instrument can touch all the surfaces of the root canal. No existing instrument. And we also want to save as much cervical and radicular dentin as possible. This is called pericervical dentine. You take the bone 4 millimeters up, 4 millimeters down. It's the pericervical dentine. And we don't want to weaken the tooth. We want to prevent fractures. The thickness of the dentine has to be at least 0.3 millimeters. And we have to prepare the canal with a continuous and uniform taper. And we have to allow a sufficient amount of irrigant to go inside the tooth and fight against the bacteria, above all in retreatments. So, the literature says shape the root canal, but there is no agreement on which is the final size of the preparation and which is the final taper of the preparation, because you have to decide it from case to case. Why with rotary files? Because they are faster, more efficient, more predictable. They allow you to have a better irrigation, and they respect the root canal anatomy. And they lead to less post-operative pain. Why? Because if we make debris extrude from the apex, we are going to worsen the inflammatory response of the host and cause periradicular inflammation. And the shaping promotes the extrusion of debris, even if we stay within the limits of the root canal. But multi-rotary files bring less debris outside from the apex, because they take them outside from the coronal third of the root canal. And so they are associated with less apical extrusion, less post-operative pain. Why? Because they were like this. If I had some debris, bacteria, pulp remnants in the root canal, and my cake file works like this, it's going to push the debris outside from the apical part of the tooth. This way. For the design and for the nature, rotaries go all in the opposite direction. And so we have the debris, and when our file rotates, they come outside from the coronal part. We are afraid of breaking instruments when we use them, above all when we start using them. But we have to know why they break. They break for these reasons. So mainly because we use them in a wrong way. We have to be trained in using rotary files. And we have to remember that we need a glide path. That is a smooth path from the crown to the apex. And we have to do it with a small tapered instrument. Because in this way we are going to optimize the root canal shaping. We will reduce the chance of apical transportation. We will reduce the chance of breaking files. And with rotary files, it's so simple because their tip is not active. If I do it with K files that are stiff and with an active cutting tip, I risk to make ledges. Blocks, I risk to perforate, go in the wrong direction. And these are all articles that show that rotary files deviate less from the original path of the root canal if compared with manual files. And this is a study by the University of Turin, Professor Elio Beruti, which is an endodontist with I think about 40 years of experience, did the glide path in an S-shaped canal with manual files. Then he picked a student of the 4th year who had never used the rotaries before. He gave him rotary files, and the students performed better than him in his first time use, because rotary files are easy to use. And in this way, we preserve the anatomy, and we have less post-operative pain. And you find several types of glide path file in the market. They all perform well. Also because you have to remember that even manual files can be broken in the canal. So it's not all about rotaries. The aim of the glide path is to transform this situation into this. Our file has to go inside and follow the path to the apex. How do? I'll scout the coronal 2/3 of the canal. If you want to do it with manual files, do it with manual files. If you want to do it with rotary files, do it with rotary files. And then, step by step, I pre-flare. I take the first 5 millimeters of the canal, and I remove all the coronal interferences. I pre-enlarge the canal. Then I can go to the working lab with my manual cake files, and then I do the glide path. But I know the anatomy of this file. And then I go on, I shape the coronal to thirds, and then I go to the apex, and I choose which is the final diameter and taper of the preparation, according to the anatomy of the root canal. I do my final rinse, I fill, I restore, and then I follow up. And this is all of the shaping. This case, sorry, the video didn't go, is no easy case because there is a calcified tooth. So I have to remove the existing restoration, and I find this. And that's a calcified pulp chamber. I can use stains. This is methylene blue to help me finding where the root canal openings are. And then I start from the easiest canal, in lower molars, the distal, because it's large, and go shaping it. And then, which is the second easiest canal in lower molars? The mesiolingual, because it's bigger and straighter than the mesiobaccal. So I start with that. Also because many times in lower molars, the two mesial canals have a confluence. So I want to shape to the apex only one canal and shape the other canal just up to the confluence. And the map on the pulpal chamber floor is guiding me to find where is the root canal opening. And you can see I go straight in with my rotary files because they find the path in an easier way than manual files. Because if I have to push one stiff file into the root canal, I apply force. The tip of the file bends. I create blocks. In this way, it's so easy. I did the coronal pre-flaring. Now what I'm doing, I am taking the working length and I'm doing the glide path. I use a lot of ultrasonic tips because there are some areas, like the isthmuses, that files cannot clean. With ultrasonic, you can clean it. So I take the working length and we finish our therapy. Irrigation, activation. I go fast because I think that the time is about to finish. So we do this. This is immediately after the filling and with the omelet. We have to define which is the shape of our canals. Are they wide and easy? I'm using a sequence. Are they regular? I can use another sequence. Are they narrow or difficult? I can use smaller taper files. It's the anatomy of the tooth that guides you to choose which file you are going to use. This case is an easy case. Narrow canals. Open the excess cavity, working length, I finish the shaping, I do the restoration. Immediately post-op, 6 months, 1 year, 2 years, follow up. The lesion is healed in both teeth. And that anatomy is completely different from this one. Filling with a confluence, so I'm using different files in this case. And we have to remember that we are fighting against these kind of things, against microorganisms that can hide inside of dentinal tubules. So we need to clean effectively. And this is a nice article. Now I'm going to quit because we have few time, but this is going to tell you which irrigant, how to deliver it, and which protocol to follow. Because we are fighting against drug-resistant bacteria in tight spaces. So we have to deliver the irrigant in an efficient way if I want it to work. So the ideal irrigant is this one. And you're gonna see that sodium hypochlorite has many of the features of the ideal irrigant because it's able to dissolve organic tissue, it is antimicrobial, it is low cost, it's fine, but it's not enough. I also need a chelator that is going to disrupt the biofilm and take care of the inorganic component that I find into the root canal. So I can use EDTA, citric acid, malic acid, you choose, but use a chelator. And don't alternate them. You use sodium hypochlorite first, then you rinse, and then you use EDTA. What about chlorhexidine? It is not advised anymore because it has a lack of tissue dissolving ability. It reacts with sodium hypochlorite and creates an orange-brown precipitate that is going to stain the dentine. And so we're not using it anymore. Your final irrigation is EDTA, 7 water. If you want to use sodium hypochlorite again, use it. How to the liver? You have to refresh it frequently because the active part of sodium hypochlorite is undergoing consumption when it reacts with soft tissues, with debris, etc. So, refresh the irrigant and develop a reverse flow, no open-end needles, side vent or double side vented needles in order to prevent sodium hypochlorite accident. And this is the protocols. Once you have finished shaping, you take 10 milliliters of sodium hypochlorite per root canal and you deliver it slowly, drop by drop. And then you rinse with sterile water, 2 milliliters of EDTA. It means that for a molar, you spend about 30 minutes cleaning. And this is the minimum, okay? If you want to spend more, spend more. And this is why if I take a short time shaping, I'm happy. And we have to balance all of these. Taper hierarchical size of the preparation, irrigation, and time that we want to spend irrigating. What about the filling? We have to seal the root canal system three-dimensionally, and we can use several techniques. We can use a warm vertical compaction of the gutta percha. I showed you before. You set your step 4 millimeters short to the working length, and then you have placed into the canal the gutta percha with the sealer. You heat until you reach the position of the stop on the reference point, and then you pack. And then, when you have done the down packing, you will do the back filling with warm gutta percha. Why do I stay inside? Because I'm allowing the gutta percha to heat before taking out my lager. And then I pack. But I can also use a single cone technique, a cold technique, with a bioceramic sealer because it is non-resolvable. So, I put the bioceramic sealer into the root canal. If you want to reduce the extrusion, you can also put it on your gutta percha point or put it inside with the K file, you choose. And then you insert your gutta percha point. And you're finished. Carrier-based technique. I put the sealer inside the canal, and then with my carrier-based system, I insert the already heated gutta percha that is going inside the root canal. Rentier, enlarged foramina, larger than 50 or 60. I cannot manage with gutta percha, I use NTA. And then I have to restore the tooth according to the residual wall number and residual wall thickness, and according to the function of the patient. So, do I have to put a fiber post or not? Take a picture. This is the protocol. We have few times, so I'm not explaining everything. But what about molars with just one wall? This says no fiber post. But is it always like this? It depends. In incisors, you follow that protocol. In premolars and molars, you have to check the thickness of the remaining wall. If the thickness is inferior to 2.5 millimeters, it's like having no wall. So in this case, yes, I put a post and I cover the cusps in order to prevent fracture. In premolar, as in molars, it's the same. So I only have the access cavity composite, no problem. Here, what do? I have 2 walls and a half left. So I do the endodontic treatment, I check which is the function and the occlusion of the patient. What do? An indirect restoration without pause here, and the direct restoration here. The function in these patients, the teeth have a higher risk to fracture than in this patient. So always check also the occlusal part of the patient. And last topic, single or multiple visit. Do I have to place a medication in infected teeth and wait for 3 weeks and then I have to fill again? No. There is no evidence suggesting that there is a higher success rate in 2 visits or in 1 visit. So the literature found out that it's more convenient if you can do everything in a single visit. The only thing that could happen is that your patient has a little bit more of post-operative sensitivity. So in this case, I have to do multiple things. In 1 visit, I do the endo of the premolar because it's an emergency appointment. And then in the second visit, I do the direct restoration here, the restoration here, and I do the retreatment of the molar. And I do immediately the build-up and take an impression. And in the last visit, I only have to put the onlay. Thank you very much. If you have any questions.
Thank you very much. That is very interesting. Các bạn, chúng ta có một câu hỏi nữa, chúng ta còn 2 phút để hỏi. Rất xin lỗi thầy Vĩnh.
Too many information.
Ai có câu hỏi không? Đề nghị tất cả các anh chị hết sức giúp cho là chúng ta kết thúc cái bài.
Xin phép các anh chị đã ngồi nghe bài từ đầu đến cuối người, các anh chị không đứng lên ạ. Khi nào mà chúng tôi trao certificate xong cho báo cáo viên thì chúng ta hãy đứng lên, chúng ta hãy cảm ơn báo cáo viên với một bài báo cáo theo tôi rất là hay. Và cô ấy nói rằng là các anh chị đừng nhút nhát như những người châu Á khác vậy. Các anh chị hãy đặt câu hỏi và cô ấy sẵn sàng trả lời ạ. Có anh chị nào có câu hỏi gì không ạ?
Em muốn hỏi cô là trong những trường hợp mà che chỉ trực tiếp ấy, thì cái vật liệu cô dùng là MTA và biodentin thì cái độ dày của cái lớp vật liệu đấy thì nó có một cái quy định nào không?
Tôi sẽ dịch câu hỏi sang tiếng Anh và các anh chị có thể nghe trực tiếp hoặc là các chị nghe đang trực tiếp ạ. In case that you do the clinical testing, what is the thickness of the MTA or biodentin?
Okay. Consider that it really depends on the size of the preparation, but at least 1 millimeter. With deep pulp cappings, you can also put 3 or 4 millimeters of META or biodentin. In small exposures, it's about 1 millimeter.
Các anh chị đều nghe rồi đúng không ạ? Dạ. Câu hỏi.
Tôi thì tôi rất thích cái ca mà cô điều trị lại trong cái trường hợp mà nó thủng sụn sàn. Cái đấy là một cái cũng khá phổ biến mà chúng tôi hay gặp. Thì trong cái trường hợp đấy là khi chị rút cái phenolphthalein ra thì nó viêm rất là nhiều. Thì cái trường hợp này có cần phải nào trong răng hay cái gì không? Cô chỉ đặt canxi ở trong đấy là nó kết thúc được.
In case that you have the for perforation,
Okay.
when you take out the tunnel fuel, the bleeding is
Huge.
uncontrollable.
Yeah, yeah.
And in this case, before placing the MTA, you need any kind of extra remove every inflammatory tissue
Okay, okay.
in the workflow.
Okay. It really depends, because if you have the inflammatory tissues that has grown inside the cavity, yes, you have to remove it. In that case, the perforation was quite recent, so there was no hypertrophic inflammatory tissue into the cavity. I had space. So the main problem was to control the bleeding. I used cotton pellets with anesthesia, with adrenaline, and I pressed for a while, for a long time. And once you have controlled the bleeding, because otherwise you cannot put the MTA because it's going to be washed out, you just do your repair of the perforation. But in case of hypertrophic tissue, yeah, you have to remove the tissue before.
Có anh chị nào có câu hỏi khác nữa không ạ?
Cô cho em hỏi là nếu mà với những cái răng mà bị thủng tràn thì mình sẽ có những cái bơm rửa như thế nào ạ? Mình sẽ dùng những dung dịch gì để bơm rửa được không?
In the same case of for perforation, how can you use the bleeding?
Can I use the irrigant?
Yeah.
Okay. It depends on the size of the perforation. Because if the perforation is small, between 1 and 2 millimeters, you can put Teflon and gutta percha to seal temporarily the perforation, and you do the root canal treatment. When you have finished with the root canal treatment, and so the irrigants have not gone through the perforation site, you remove the Teflon, and then you can seal the perforation with MTA. But in case of large perforation, you cannot manage it. And so you seal the perforation first, and then when the MTA has set, in a second appointment, you do the root canal treatment.
Rất hay đúng không ạ? Bạn có một câu hỏi khác nữa rằng là bạn ấy hỏi rằng là trong trường hợp mà bơm rửa, những cái sử dụng protocol bơm rửa là khi mà chúng ta sử dụng các loại dung dịch khác nhau, ví dụ như sử dụng hypochlorite đi và chuyển sang EDTA thì có cần phải làm gì không? In the protocol of irrigation, after you use sodium hypochlorite, which kind of solution you use before switching to EDTA?
Sterile water, no saline, because saline is going to create some precipitate that is going to attach to the walls of the root canal. So sterile water, the same that you put into your autoclave, is fine. You use it because it has been studied that if you put EDTA immediately, the chlorine of sodium hypochlorite is going to react with EDTA. So EDTA is not going to be fully effective. And so you need to rinse between the two. And that's it, only sterile water.
Ở đây chị nào có câu hỏi không ạ? Thank you for your very nice presentation.
Thank you.
And on behalf of the organizing committee, we would like to say thanks for your help and